Good afternoon, everyone. This is Sydney from TechServe Alliance. Welcome to today's webinar, the TechServe Alliance Health and Benefits Program, HRA. There will be a question and answer session after the presentation, so feel free to write in any questions you want answered in the question box on the right side of your screen. We are also recording today's presentation, which will be available to TechServe members on the TechServe Alliance website and will be sent out in follow-up emails. I'd like to introduce our speaker, Mark Roberts, CEO of TechServe.
Thank you so much, Sydney, and welcome everyone. This is actually our last installment of our fall webinar series on our health and benefits program. And I'm pleased to introduce in just a moment Bob Gaidos, who's the founder and CEO of Pandela. And just a couple of comments about Bob. I've mentioned this before, but I really haven't encountered anyone more knowledgeable or more innovative in the health and benefits arena. We started this partnership about a year ago, and the number of new products and new offerings has just been amazing. And what I am really excited, and Bob's going to talk more about it, is a way to really score and ultimately price health plans without having to go through all of the hassle associated with getting claims data or have your employees fill out applications. So we really think this is a game changer, and we're really excited about TechServe members and those others in the industry being exposed to these opportunities first. So before I do that, the other thing I want to add is we recently just switched with Pandela taking over our health and benefits, and the experience has been phenomenal. They use a GoCo app, which I have to say is probably the easiest interface I've ever experienced, certainly in the health and benefits arena, and for that matter, in many other areas. Incredibly seamless application, and so just have had phenomenal feedback from the staff and just my own personal experience. So with that, I'm going to turn it over to Bob and look forward to everyone's engagement and questions. Bob?
Great, thank you so much, Mark. Don't forget, as we're going along, you can type your questions in the box, and I'll see them as I'm moving along here. So we're going to talk about the level funded and self-funded plans again, but this time we're going to talk more about the new big data underwriting that Mark was just mentioning. We'll go over the virtual direct primary care. We've gotten a lot of traction there. People really like it, and we're putting in some of those in place in some employers. The virtual direct primary care can become a minimum essential coverage plan, and it can be combined with a minimum value plan as well. We'll talk about that. Talk about the individual coverage HRA, also how to just have better coverage with a traditional first dollar coverage health reimbursement arrangement, and then talk a little bit about the end about one way to really reward employees is with disability insurance. So on this slide, and some of you perhaps have seen it before, we talk about the differences between, large group fully insured, large group level funding, and I've actually added large group self-funding because some of the employers that are part of TechServe Alliance are actually large enough that they really should be doing more traditional level funding or traditional self-funding. We had a couple of those recently in the last couple of weeks. So, when you're large group fully insured, you are being underwritten. You're being underwritten based on your demographics, your industry, your claims history, which the current carrier would have, and then they're blending it with their own block of business, and how much they blend it depends on your size. If you're like 50 employees, they're going to 80% blend it. If you're 500 employees, they're probably only going to 20% blend it. And if you're 1,000, they're not going to blend it at all. But if you're fully insured, the carrier holds those reserves. And additionally, you have to pay premium taxes, and there are state mandates that might apply. In level or self-funding, you're underwritten on demographics, industry, and claims history, but you're not being blended with the carrier except for your really large claims, which are above the stop loss. And the reserves are actually your asset, and because it's an ERISA plan, it's not subject to premium tax or state mandates, which can right off the top save a few percentage points. So level funding a lot of times makes sense when you're fully insured and you want to move towards self-funding, but you don't want to take the risk or you have limited amount of data to move over. And level funding is an arrangement with a carrier saying, well, here's what we'll do. We'll create premium equivalents and you'll pay us what looks like a premium. And we'll take some of the money and buy planned administration. We'll take some of the money and buy stop loss. So the claims above, say, 50,000 are insured. And then we'll put the balance into a claims fund. And depending on the level funded carrier or arrangement, you get a 50% rebate or sometimes 100% rebate or sometimes a credit towards the next year's administrative renewal, depending on the carrier. And obviously, if you're going to let the carrier have half of that savings, that allows them to pull a little bit more and take a little bit risk in moving you over. But as you get larger, that claim pool gets pretty large. We were working with an employer recently and their claim pool is $1 million. Well, that's a large enough pool that you really shouldn't do level funding. You really should do true self-funding, because the only thing different between level funding and self-funding is you're not going to fully fund the claims. You're not going to let them have the money and sit it in a bank account. You're going to hold it in your bank account and just pay as you go. And it's always going to be 100% refund, not a 50% refund. So, if you're a smaller employer and you're 75 employees and maybe the claim pool is only $250,000, making that 50-50 trade with the employee, with the carrier to be able to get into level funding makes sense. But if you've got a large pool of claims, say $1 million, or you grow, we saw that recently where somebody started with level funding because they were 70 employees and then grew to 250. Well, at that point, it's time to leave level funding and go to self-funding, and we can manage all that for you. When Mark was talking about the underwriting and the big data, let's just go through that. You're underwritten. If you have more than 50 eligible employees, you are underwritten. Everybody in the United States is going to underwrite you, okay? Only if you have less than 50 employees in the Affordable Care Act is it community rated. Now that's different if you're in California and New York. In California and New York, it's actually up to 100, but in all the other 48 states, it's only up to 50, and then above 50, you're underwritten based on the demographics. Well, that's simple. Give us a census. The health summaries, that's simple. Give us the current benefits that you have. The employer contribution, that's simple. Tell us what you do. Where it gets difficult and where it becomes a hassle is they need to recreate your claims. They need to be able to guess what your claims are going to be. Well, give them 2 years of rate renewals. Hopefully you have access to that, okay? Where it gets really difficult is they'll say, well, we want 2 years of paid claims. And that's especially going to be true once you get into the 100 to 250 area. And maybe you don't have access to those claims. Maybe you switched from a carrier last year and you didn't leave with the final claim reports, and now your new claim reports are immature. Or maybe you just don't have access to them, okay? Maybe that carrier doesn't want to give them to you. In some states, if you're covered on an HMO, they're not going to give you your claim data, right? Okay, what do? Well, at that point, a lot of the underwriters are saying, well, we want a health questionnaire. And that can be difficult to try to get, 75 people, 125 people to fill out a questionnaire. Well, we have now, we actually had it with a couple of carriers in the last several months, but now it's been expanded as the ability to do big data. So Cigna and Aetna have been using a big data source, Milliman GRX, but the other carriers have not. And that big data source, can eliminate the need for the claims. Well, we now have another data source company called Verify, and they're being used by 3 carriers, including, for example, Humana, and 6 underwriters. And those underwriters are the underwriters that are actually underwriting the level funded plan, the proprietary TechServe level funded plan that we launched. So that allows us to underwrite without the claims. We just need the census. Now they are asking for a couple things on the census that maybe you don't normally give, which is the street address, city, state, and hopefully phone number, because that allows them to find an even better match with that big data. If you look at what was happening in the past several years with companies like Aetna and Cigna, when they were using the Milliman GRX, what they were doing is, you could imagine the name, RX. That is, they were doing a database on prescriptions. What prescriptions was your group taking? Because they can actually give it to it. Every prescription you ever take is actually reported to the Medical Information Bureau. And you can actually give a census to companies like Milliman, and they'll give it back, and it's anonymized, and then they'll score it and say, well, based on what you gave us, this is a low, medium, high risk group when it comes to prescriptions, and here are some high-end, losing my mind, high-end diagnoses that we found. Okay, because obviously, if you're taking certain drugs, we know the diagnosis. Well, this new one, Verica, is expanding that even farther and bringing in consumer data and bringing in network data by the zip code. So we literally just got access to it yesterday. We're actually working with some of you already on it. I've got phone calls this afternoon with 2 of our underwriters on it. So we are very excited, as Mark said, because it means that if you qualify and you have that census data, it's going to let us know whether you are a good candidate for level funding or self-funding, and it's going to give the proper data to the underwriter to be able to underwrite without that claim data or those medical questionnaires. So we're really, really excited about it. Now, I said, normally you're going to give us data we need, first name, last name, date of birth, gender, zip code, that we always get from employers. But they're also asking for street address, city, state, and phone number, so that the match can go really good into the databases. Have to have 50 enrolled in order to do that. 25 in some markets, that's going to vary a little bit by the state. As I said, we have 6 stop loss carriers that are accepting this process and 3 level funded carriers, including Humana. And then that low score, it is possible that they might have additional data needs, but there's a very good chance we're going to get right through just using that census and the normal data that we already talked about earlier, such as the plan designs and your contributions and your renewals. So very, very excited about that. Because I said we got access to it yesterday, we jumped right in. Some of you are already working with us on it. And I've got those calls with the carriers this afternoon. Also gaining a lot of momentum with this product, the direct primary care product. Just had a call recently with one of the members about this because, they actually already had a major medical plan in place, as most of you do, that meant that they weren't subject to penalty A or penalty B, but they were running a minimum essential coverage plan as well, because some of the employees wanted the minimum essential coverage plan to supplement the deductible plans. And this is a significantly lower cost way of doing that. So this plan, Healthcare to You, and this is special pricing for TechServe. This is significantly below the street price, probably about almost 35% below the street price. So what it says is coast to coast, 50 states, unlimited direct primary care, $10 to see the office, $25 to see the urgent care, your annual physicals, unlimited chronic care disease management for these 13 chronic cares. If you want to do a virtual, then there's no copay. And it's only $50 for a member, $90 for a husband and wife, $130 for a member with children, and $175 for men with a family. You can have it be voluntary. You could contribute towards it. It's totally up to you. We can have you just give them a link and they can buy it with a credit card, or you can put it onto your benefit administration system and do it with payroll deductions. So enormous flexibility on it. And once they're on the system, it's very simple. They go to the Apple Store or Google Play, download an app called Health Wallet, log in with their social security number, and they're off and running. And then inside of that app, they're going to speak to the Healthcare to You centralized scheduling department, and that department will help them find a local doctor that they can see for $10. They'll guarantee that it'll be within 15-minute radius of their house. Help them find a urgent care clinic, same thing, within 15 minutes of house, $25. And chronic care. Now, if they assign you a doctor and you visit that doctor and you like that doctor, you can actually keep that doctor as your primary care doctor. And then the virtual care is $0. Any of the care that you receive is inside of a single medical record. So as you go from the office to emergent care to the telemedicine, they're all going to have access to your records because it's all inside of the app. No limit on the number of times they can see a physician. It's not health insurance, very important statement, so I'm going to repeat it. It's not health insurance. It is a membership because it's direct primary care, okay? So since it's a membership and it's not insurance, it does cover pre-existing conditions. And so anything that that doctor can treat in that office or anything that doctor can treat in that urgent care clinic is covered. Obviously, if they need to send you to the hospital, that's not going to be covered. There's not a list of clinics to see. What they're doing is watching capacity in the marketplace and finding available doctors. That's how they're doing it. If you have Medicare, Medicaid, TRICARE, you cannot enroll because those programs have their own direct primary care programs, and it is bilingual. Now we've got a couple of questions, a quick question. One was California, what is the definition of large group? Great question. So the definition of large group is 1 to 100 in California. That said, we can do level funded plans in California and actually do them all the way down to 5 employees. But obviously you're not going to have access to your claims. So the big data that we just talked about will be very important to get you underwritten, but we won't be able to use it till 25 employees. So if you had 15 employees, you would have to do the medical questionnaires. Can an employee, great question. Can an employee continue this direct primary care plan on their own if they leave the employer? Absolutely. They absolutely can do that. Not a problem. Now, if you're a large group, whether you're fully insured, level funded or self-funded, right, your cost is related to your claims. And Milliman is saying through a study that they just did, which is not surprising at all. I've been doing this 30 years and we were doing a lot of direct primary care in physical locations 15 years ago in markets. Not surprising to find what they found, which is that when direct primary care is in place, the claims are 20% lower. 40% fewer emergency room visits, which creates a 53% reduction in the cost of the emergency room and 25% lower hospital admissions. Those are huge numbers. So if anything, this tells us any employer over 50 should be running this program because it's so cost effective against their health plan, because it just makes total sense. Now, minimum essential coverage plans. Quite a few of the TechServe members are using minimum essential coverage plans. Now, if you have a major medical plan, almost all of you do, and you're offering it to all of your employees, regardless of whether you're asking them to contribute or not, that passes penalty A. So the only reason you would need a minimum essential coverage plan is if what you were doing was, hey, I'm going to offer the major medical plan to the salaried, but I'm not going to offer the major medical plan to the W-2s. Then you would need a minimum essential coverage plan to avoid penalty A, because let's say you had 100 people that were in that W-2 consulting class and you weren't offering them the major medical plan. If you didn't have a minimum essential coverage plan, you'd be subject to penalty A, which would be a lot. It'd be 70 times 2,500. Okay, so a lot of you will put a minimum essential coverage plan in place if you're doing that. Now, there's no need for the minimum essential coverage plan. Use the healthcare to you instead if all you're really trying to do is get affordable coverage in their hands. Okay, and I see that a lot. I see a lot of times where what we're doing is, well, we got the salaried people, and maybe we're paying 75% of the single and the salaried, and then the W-2s, maybe we're paying 50% of the single, and that creates a high payroll deduction, and so a lot of them don't take it. So you put a minimum essential coverage plan in place because you want to give them something affordable. Healthcare to you is a better version of that, okay? Because there's not a lot of coverage in minimum essential coverage. The healthcare to you would actually be more than that coverage, okay? So I think that that's a real viable alternative. Now, the second penalty that can hit you is penalty B, where you're offering a minimum value plan. So in all ACA large group, small group plans are going to be minimum value. So you have a major medical plan in place and you're offering it, but you're not contributing to it, or you're contributing some small amount. Then the affordability test comes in play, which is if that's a big if, capital I, capital F, if they went to the state or federal exchange and qualified for a subsidy because their income was below the 450% of poverty level, then you would be subject to you'd be subject to a penalty if their payroll deduction was greater than 9.78%. Well, a lot of you have done the math on it and you understand that risk. So I will see sometimes where a minimum value plan is in place. I've seen times when there's maybe like 400 people who are making $15, $20 an hour, and so you're worried about penalty B because because your contribution to the major medical is so high, or you don't even offer it's just a minimum essential coverage plan. Well, we've got a new plan. We're going to talk about it in just a couple slides to help you out with that. Okay. How much is the membership? Let me just go back and show that again. These are the membership dues right here. $50 for a single person per month, $90 for a husband and wife, $130 for a member and children, and $175 for a member and family. Those are the membership dues to join Healthcare to You. Okay, so let's go back here. The only thing that you have to have a plan be minimum essential coverage is the ACA preventive coverage, which is on the screen. This is not a lot of coverage. It's just preventive. Okay. So a lot of times people will have a minimum essential care plan, a MEC plan in place, and the only thing they'll have is the ACA preventive coverage, which is obviously very minimal coverage. So what we can do with Healthcare to You is we can add this coverage. We can add that coverage to Healthcare to You, and additionally put in a RX program that'll have 36 acute medications at no cost and the other ones at a discount. And now it's a MEC plan. So it's not just a awesome front end coverage at an affordable price. Now it actually passes the test for penalty A. Now obviously that means the rates go up a little bit to 95, 178, 243, 312. So if you wanted to do the Healthcare to You program and have it be a MEC plan because you needed it to be able to offer it, we can do it. Minimum 2 employees, okay? No contribution requirement. Additionally, you could give a choice. You could actually say, hey, if you want the MEC plan, it's $95. If you don't want the MEC plan and all you want is Healthcare to You, it's only $50, and we could do both. Now, we can take it a step even farther. If you really need to offer both the MEC and the MVP, then we can put it together with a program called Ease Health Plans, where we can take the Healthcare to You program and put it together with Ease Health Plans. And they will now say they have to have a minimum 10 enrolled. There is no underwriting. They cover the COBRA. It has a benefit administration if you want it. So now you could come out and you could say, I have a minimum essential coverage plan and a minimum value plan. Choose the one you want. Now you're going to pass penalty A and penalty B. Okay. And it'll include Healthcare to You. Now that's obviously a little bit higher, all the way up to 135 for a single, 414 for the MVP plan, because you're deliberately trying to make sure you're passing penalty A and penalty B, and we're not underwriting, so we have to have the price a little high, but as a minimum of 10 enrolled. So you know that everybody's going to get access to this plan, and then those are the premiums, okay? So really excited about what we can do with the Healthcare to You, have it become a minimum essential coverage plan, and then also put it together with a MEC plan and MVP, and already engaged with quite a few of the members on this. Now, the other thing we've been talking to quite a few of the members about, is getting a little bit of momentum so far, is the individual coverage HRA. I think we'll see a lot more of this in the coming weeks, because a lot of times the smaller employers aren't really shopping their renewals until November, because they don't have them until November 1st. Now you can do individual coverage at any size. It doesn't matter, but I think it might be more popular with the groups of 15 to 25, or if you're trying to carve out a class, and I'll go into that because that could really work. So this, we talked about it last year. It was brand new last year. It barely got out to the streets in time in November. HRA, as we know, stands for Health Reimbursement Arrangement. Well, it's been around a long time, since 1953, and a lot of you have probably used a HRA over the years to reimburse employees for their deductibles. Well, as of last year, you can use that same vehicle, Section 213 of the IRS code, HRAs, to reimburse people for their individual ACA health insurance premiums. So think about that. If you have an employer-sponsored plan, you choose the carrier. The carrier tells you that you have to have 50 to 75% of the people participate. They usually tell you got to contribute at least 50% of the employee-only premium. They're only going to allow one carrier, unless you're a small group in California and DC where the exchanges exist. Maybe they'll let you have 2 or 3, occasionally more. And then you have payroll deduction, which creates the reconciliation. Instead, with an individual coverage HRA, You're just telling the employees, no, go buy whatever plane you want. Go to the state and federal exchange. You choose the carrier, you choose the plan, and then I'll reimburse you as an employer up to whatever amount you want. So you could say, I'll reimburse you up to $200 for a single, up to $400 for a couple, up to $600 for a family, or I'll reimburse 50% up to $500, or whatever you want. Or I'm only going to pay the single. I'll pay the single, but nothing else, whatever you want. You're in total control of that. Okay. It is really that simple. And what we have done is partnered with Take Command Health. You can schedule on our website a meeting with them. They'll help you design it, because you can do classes. I'll talk more about that in a second. They help you design the coverage and all that. They onboard the employees. They even help the employees enroll in the individual ACA plans in all the states. And then they give the employees the website or phone app where they can request their reimbursement, and they process the reimbursement, and then they're just coming to you once a month for you to cover that bill. So they're going to help you design how much you should give, 200, 400, 600, 50% to 250, whatever you want to do, waiting periods, no waiting periods, want to do classes, because you can do classes. They're going to help you design all that. They'll help you with the tax reporting and the compliance. They charge $15 per employee per month, plus a $15 platform fee. So if you had 10 employees, it'd be 10 times 15 plus 15, so $165. They also have this SMART program, which is more expensive, but it has access to people to help schedule the doctor appointments or coordinate care or medical records, and 24/7 telemedicine, and a little bit of dental and vision discounts included. Okay. You do avoid both penalty A and penalty B, because these are ACA plans. Now, in order for it to be penalty B, and they'll work with you on that, you have to make sure that you're contributing enough to avoid that 9.78. Okay, and they'll help you figure that out. So really, it could be a very, very good option for you. Another thing we've been talking to members about over the last couple of months here is, don't overlook what you can do with an HRA. Over the years here, I've seen deductibles grow quite a bit. It's pretty common for us to see deductibles of $3,000 to $5,000 on the TechServe Alliance member health plans. And of course, that creates a situation where the employees are like, man, I don't have any coverage up front, right? Which creates your desire to want to give them healthcare to you. But other things you can do is you can do an HRA, okay? Now, one way to do an HRA is if you have a $1,000 deductible, you can just move it to $3,000 and take the savings and then fund the difference. Now, if you're already at the $3,000, you could do it maybe by trying to move it to the $5,000, or you could just decide I'm going to give them a little bit of coverage up front because I want to help them out. I give them $500 and they can use that any way they want. And we'll help you design that and do what you want with that HRA, but don't overlook what you can do. It is a very flexible vehicle, and it's a way for you to reimburse employees. So you could do a lot with HRAs. You can say, hey, I'm going to give you $1,000, but it's only good for inpatient, outpatient. I'm going to give you $1,000 and you can use it for anything that's medical. I'm going to give you $1,000 and you can use it for medical and prescriptions, or you could exclude prescriptions. You can even say, I'm going to give you $1,000 and you can use it for medical, prescriptions, dental, and vision. Okay, I don't care what you use it for, just use it. Because maybe that's just a way to take care of the employees. So it might be just an affordable way to say, well, if I gave everybody $500 and I multiply that times my enrollment, that's an affordable way to get something in their hands and make them feel like they've got some benefit. Because at the end of the day, why are you doing what you're doing? It is a benefit. It's supposed to be a return, okay? That they are grateful that they have this, and you get a return in attraction and retention. This is just a slide showing an example of, if we were able to design a plan by moving the deductibles from $1,000 to $3,000, whether we did that with fully insured or level funded, let's say it saved 30%, and you could take 18% of that savings and fund the difference between the $1,000 and $3,000 deductible, which is $2,000 and $4,000, because they're only going to spend on a high end 67% of that money, and that creates better coverage and a savings. Now, another thing I'm going to talk about as far as, why do you do what you do? Okay, make up the number. You're spending $5,000 a year per employee to run a benefit program. It is to get a return. The return is attraction and retention. That's what you're trying to get, right? Well, think about the things you can put money in, from health insurance to dental, to vision, to life insurance, to disability, whatever, okay? Every dollar that you put in health insurance is a very diminishing return. Let's say you were going to put, $300 a month towards a health plan. Whether you gave them $300 a month towards a health plan or $275 a month towards a health plan, it ain't enough, and they're not going to be appreciative, right? You're just doing the best you can. There's no return on that $25. You take that $25 and you put it towards something else, say long-term disability insurance, say dental or vision, that can get a return. Dental and vision rarely goes up. It's an affordable benefit, and it's pretty much been the same premiums for 20 years. Why? Because it's a defined benefit, $1,000 a year, $2,000 a year, one visit a year, one pair of glasses a year, one set of contacts a year. It's a defined benefit. We know exactly what it's going to cost. It's not subject to the medical inflation that health insurance is. Health insurance is subject to huge inflation, right? Because over 50% of the claims are actually going to large claimants, and those claims are increasing at 3 times the rate of inflation. That's not true in dental, vision, or disability. And disability insurance, well, it's tied to your payroll. So it only goes up with your payroll. It goes up with your head count because it's just a percentage of your payroll. And it's a great benefit. I have met a lot of the members in the last year and a half here, and I don't see very much disability insurance. It's pretty rare, actually, that I see it. If you think about who you're employing, I see a lot of high salaries. I see a lot of high wages. The disability coverage might be the most important thing you can do. We have a program with Unum where we can do guaranteed issue for group and individual, okay? And you can discriminate by job class with disability. So you can say, I'm going to give better coverage to the management than I give to the consultants, or I'm going to give the coverage to the management and not to the consultants, or whatever. You can discriminate by class. You can discriminate by class within the consultants. This class of consultants gets the disability. This class does not get the disability. Okay. And you could say, I'm going to put it in place. I'm only going to pay for it for the management team, not the entire salary team, just the management team. But since you put it in place, the entire company now gets access to it at a guaranteed issue. That's possible. Additionally, for the higher wages, we can even put an individual disability policy in place that'll be guaranteed issue, depending on the size of the group, at least 5,000, maybe more. For the higher paid individuals, and that individual policy goes with them. So you might have somebody making $200,000 a year, and the group disability plan pays $10,000, and it might be taxable. So if they go out on disability, they're lucky if they're taking home half their net pay. They can buy an individual disability policy on their own that supplements that. And then that policy they can take with them. There is a lot of things you can do with a group and individual disability policy to reward employees, to attract employees, to retain employees. And it's enormously cost effective because you can discriminate by class and it's not subject to inflation. So I can't stress enough seeing so many of the groups and how many don't have disability and how high some of these wages are about disability. Now, maybe I'm a little biased towards disability because my father was lifetime disabled. At 55 years old, he was working for a company at a factory, and at the end of the shift, fell 25 feet off of a ledge onto a railroad track and never worked again. But he spent 2 years in court with the workers' comp trying to get his money because they were trying to make the claim that he wasn't at work, right? He had an individual disability policy from MetLife, and that's what they lived on. My mother was forever grateful for that. Disability can be a devastating thing when it hits. It can change lives. So love to talk to you more about that. I should have put some slides. I'll just talk about it on the GoCo administration system that Mark was talking about. So let's talk about that because, just today we got an email from a group that is moving forward with this, and it's like, hey, my current broker has this online benefit administration system. Do you have one? Yes, we do. So if you're already using an online benefit administration system and you're happy, great, keep it. okay? If you're not, and you're only using paper, well, we've got this great system. Or maybe you're using a system and you're not happy with it. So it's called GoCo. We can get demos scheduled. Tom used to put it in emails. Tom should put it in emails that just send out afterwards, invite people to get a demo. And it actually does three things. So the base model, which is available to members for no cost, administrates benefits and has some HR tools. Totally online, really, as Mark said, an incredible, awesome experience. Depending on your payroll company, it might actually integrate with your payroll company, but at the very least, it'll provide a report out to the payroll company for the payroll deductions. It has another module that we can turn on. I think it's $5 per employee per month to turn it on, which is an upgraded version of the human resource tool. And then if you want, it even has a payroll tool that can be added as an embedded payroll, which we can add. I think it's $8 per employee per month. And you can add the payroll system as well. And then you actually would have benefits, HR, and payroll all integrated in one. So again, that's it. The base model. The administration is at no cost to you, and really super easy system, very modern interface to use. So let's review what we've kind of covered here today and maybe a couple other things. And well, I thought I had another page and I guess I don't, so I got to do it from memory. Let's go back to the agenda page. That'll remind me what I was going to go through, because I think I had a closing comment page and I accidentally deleted it. So level funding and self-funded plans. Enormous interest, a lot of people talking to us right now. We're moving forward with quite a few. And we know that it can sometimes be a hassle with the underwriting if you don't have access to your claims. And so we've got this new big data underwriting. Now, remember, underwriting is a double-edged sword. You may find out that you don't qualify, or you may find out that you qualify. And also, we can use it for the smaller groups. Even though, let's say you got a group of 15, the underwriter's still going to ask us to do medical questionnaires. We could still run the system, and the system will come back and tell us, yes, this group scored really well, or no, it didn't, which will help you decide whether or not you want to do those questionnaires on the smaller group. So very excited about the system. Just got access to it yesterday, working with about 10 groups right now on it. Got a call, as I said, with the underwriters today at 4 and 4:30. The virtual direct primary care, it's a lot of excitement about that moving forward with employers. It can easily be turned into that minimum essential coverage or a minimum value plan. Okay, so clock is ticking. It's October 29th. Most of America renews on January 1st. So we're here to help you, and we certainly look forward to hearing from you. Mark, any closing comments that you want to make?
Yeah, great overview, Bob. I really encourage you first. I know there's a lot of information because of all the innovative products. Really encourage you to set up a time to talk to Bob and Tommy, who's dedicated TechServe team member dedicated to benefits. And then to really emphasize what Bob said, which is with COVID, you know, a lot of folks are shopping their health benefits. And so the underwriters are getting backed up, so you really need to move sooner rather than later. So really encourage you to have a conversation. Many of these offerings are exclusive to TechServe, and so reach out. You know, set up a call with Bob or Tommy, and find out if one of these offerings makes sense for you.
Super. Well, thank you, Mark.
So, yeah, go ahead.
And thank you, everybody.
Yeah, thanks, Bob. And, you know, and again, if anyone has any follow-up questions, just feel free to reach out to us.
Great.
Well, thank you to Mark, Bob, and the attendees. I want to remind everyone that this presentation was recorded and will be distributed in follow-up emails. Please check back for future webinars to be scheduled. If you have any further questions, please send them to staff@techservealliance.org. Have a great day.